Coming up today, knowledge is power, where to go and what questions to ask if you are at higher risk of breast cancer. Plus, meet a woman who makes quite a journey to get her preventative care here. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Screening and genetic testing can hold the key to early detection and breast cancer survival. Mikayla Stover has known for years that she is at higher risk for breast cancer. But she's not just sitting around hoping to avoid it. She's being proactive and going out of her way to do it.
You see all the bumper stickers that say cancer sucks, and it just really does.
That's because while in high school, Mikayla Stover watched her mom go through it.
She went through the whole thing. She went through cancer treatment, she went through remission, and then diagnosed again.
Her mom died from breast cancer at age 56.
At that time, I had just had my first child. He was 3 months old when she went into hospice and 5 months old when she actually passed away. And that whole experience was, I learned a lot about myself.
Including she does not carry the BRCA gene mutation like her mother and brother do, but that she is still at a higher risk of developing cancer.
Different cancer presence in my history, and so that puts me in this place to be into a cancer prevention plan.
A plan made through the high-risk breast clinic at the University of Kansas Cancer Center.
It's called a Tyrer-Cuzick risk calculator, and it's a way we have to estimate a person's risk for breast cancer when there's been a family history of it.
And while healthcare close to home often makes sense, where Mikayla gets her preventative care matters, which is why she makes the annual 3,000-mile trip from Costa Rica to Kansas City, Kansas for her mammogram and further testing.
So your last mammogram was April 24th of last year. So we can get it while you're here. How long are
Any kind of data and statistics help inform decisions and care, and it's nice.
So we say mom had breast cancer at 44.
I'm very quick to say, like, I am well today, and this is all preventative care. It's all trying to be proactive, and I, apply that to everything in life, like how being proactive is like a good approach to almost anything, and that also comes in effect with our healthcare as well.
Proactive, that is the word of the morning. Such a great message from Mikayla Stover, who joins us live from her home in Costa Rica this morning. Good morning.
Good morning. How are you?
Great. Looks great where you are, and we just appreciate you getting up and sharing your morning with us to share your story. In studio, we have one of your doctors, breast medical oncologist, Dr. Carol Fabian. Dr. Fabian is the director of the Breast Cancer Prevention and Survivorship Research Center at the University of Kansas Cancer Center. Dr. Fabian, are people getting the genetic testing that they need? When should somebody get one? What should they be looking for, especially if they don't know their family history?
Well, most people actually who get breast cancer do not have a mutation in BRCA1 or 2 or any of the other genes that are associated with heightened risk of breast cancer. So the first thing that we do is actually calculate somebody's risk based upon the same model that was used for Mikayla, the Tyrer-Cuzick model that takes into account all kinds of things. When they had their first baby, what their breast density is, if they're over the age of 40, their family history, who had breast cancer, the age of breast cancer. All of these things are very important in determining risks. As to the second part of your question, who's getting genetic testing? Is everybody getting genetic testing? When should I get genetic testing? Basically, if you had a mother or sister or grandmother, either on your dad's side or an aunt, on your dad's side or your mom's side, you should at least consider genetic testing and talk to somebody about it. It used to be that genetic testing was hard to get covered by insurance and cost $3,000 to $4,000 just to have BRCA1 or BRCA2. That's when things first started. Then there became much more economical ways to do gene testing. We now test commonly 44 or 88 genes for about $250. And instead of a blood test, you can actually spit in a tube.
So about as simple as that.
As simple as that. We like to have the affected individual have the test first so we know what a positive or negative test means. But If that person doesn't want to get tested, that person is deceased, or for whatever reason, if you've had a relative, close relative with breast cancer and you want to get tested, we can get you tested for a reasonable amount of money.
Mikayla, we heard a little bit and saw that picture of your mother in the video that we just showed. Talk a little bit about her and just what was that like watching her go through that?
You know, watching your parent, I was in high school, so watching your parent go through something like that is confusing and scary, but also inspiring in a way, because of the supports that we had and the way that she approached it. She approached it with aggression. She approached it with trust in her providers, and she had a great care team. My dad was really supportive, and her mother was there as well to support her. And it was something that was hard but attainable.
And of course, you didn't want your kids to go through what you went through. So how did you go about getting the genetic testing, and when did you get that?
Yeah, so in 2010, I was pregnant with my first, and she called me and said that she had gotten tested and it was positive. And she shared with me how that was actually sort of rare in a way, and that her having a positive test meant that I was 50% likely or unlikely to test positive as well. So I quickly, as soon as I had my next checkup for my pregnancy, I immediately asked if I could get genetic testing, and my provider had a lot of questions for me, but we went ahead and did that right away.
So Dr. Fabian, Mikayla is a patient in our high-risk breast cancer clinic. You are credited for the research that prompted this research for people at high risk. Tell us about the inception of this clinic to help patients like Mikayla on the research side.
Well, this clinic basically started back, believe it or not, in about 1990. And it was prompted by my experiences treating young women with breast cancer. We didn't even know about BRCA1 or 2 then, that received state-of-the-art screening, received aggressive chemotherapy, but too many of them still succumbed to breast cancer. Obviously, both screenings improved since then, and we have genetic testing. We have much better treatment for breast cancer. So less than 20% of women diagnosed today will ever die of breast cancer. But they, as Mikayla mentioned, they have to go through a lot of treatment that is very difficult oftentimes. So the earlier people are diagnosed with breast cancer, the less likely they are to die of it. But the idea of the high-risk breast clinic was to identify those women at highest risk so we could intervene and perhaps prevent them from developing breast cancer in the first place, prevent them from having all the side effects from treatment.
So what's new in the approach to breast cancer prevention? You say back in the 90s, which doesn't sound like a long time ago, but it actually really is. So how have you seen this approach change to preventing breast cancer in women?
Well, there, I think, are two fundamental approaches. One is now we look at breast density, and I think you have a picture of what is dense breasts later on perhaps in the show. And for people that do have dense breasts, we recommend, in addition to a mammogram, we recommend a yearly breast MRI. What's changed in the last 5 years is we don't necessarily have to be in an MRI machine for 20 minutes, which is not comfortable. We have what's called an abbreviated or limited MRI. It's much less expensive, much more comfortable for the patient, and much less likely to cause a false positive test. So that is one very important thing. We assess density. Density increases your risk. It also makes it harder to find a cancer. If you have dense breasts, we suggest and you're at increased risk, we suggest an MRI in addition to the mammogram. That's number one. Number two, we don't just give tamoxifen to everybody.
And what is that for? Explain to the audience.
Tamoxifen is a very old drug. It's an anti-estrogen that we have used for decades to treat breast cancer. It's a pill, and in full dose it reduces the risk of breast cancer by about half. So that's wonderful. The problem with it is it causes hot flash and other side effects. And we would like to avoid those side effects, especially if you don't know that you're going to get breast cancer. You're a little reluctant to start having hot flashes and menstrual period problems. So there have been multiple other approaches that we're testing here. They're designed both to decrease the side effects from anti-estrogens like tamoxifen. So we have low-dose tamoxifen. We have new drugs that don't cause those hot flashes at all. And we're looking at differences in lifestyle approaches.
That was my next question, is just what are some healthy behaviors that we can do, give us some power in our daily lives to help prevent breast cancer?
Well, thank you for asking that. Actually, for most women who are considered at moderate risk for breast cancer, and that is most women who identify as high risk, the healthy behaviors approach, along perhaps with this MRI, is all they really need to do. These are all the things that your mother told you in kindergarten.
Really, she was right all along?
She was right all along.
Gosh.
So you need to get out there on that playground, put that computer down, and
activity
try
is
to
key.
get 3 to 5 hours a week of aerobic exercise. And that could be something as simple as fast walking. That's probably the most important thing for a young woman, a premenopausal woman, to do. Make sure you get an adequate amount of vitamin D, that you don't have more than 3 to 7 drinks of alcohol a week, and keep your weight in a healthy place.
I think these things are doable, but it's hard. As time goes on in our lives, it's not always easy. Things get away from us, but I think to know that there's things that we can do to kind of take that control back is nice.
Right. Probably the behavioral thing is the hardest thing for most women. So if you have a very busy life and you have a job that mainly involves you sitting at a desk all day, it's hard to get in that exercise. If you've already gained a lot of weight, it's very difficult to lose it. So we have several different protocols that are aimed at some of these life phases. One with low-dose tamoxifen, for example, for premenopausal high-risk women. Another protocol with a weight loss drug that can help women that are seriously overweight lose weight, and then lifestyle modifications to help them keep it off.
So there's options. Mikayla, come in here and talk to us about your healthy habits. Physical activity, as Dr. Fabian just said. You shared some photos from your life in Costa Rica. I take it you spend a lot of time outside, being healthy and active. What kind of things do you do?
Yeah, my husband and I usually walk most mornings, and I walk with a weighted vest to add a little help there. And sometimes I run, but every single day I do strength training. I know the importance of strength training. Lots of yoga. He does yoga twice a week. I do yoga once a week. And we like to hike. And it's not just the hikes around Costa Rica. We like to do challenging hikes, maybe once a year, once every other year, doing 14ers or big climbs in other locations.
Nice. It's just part of your kind of baked into your lifestyle. And it's nice when you have a partner who likes to tag along and be healthy too. So that's great. Dr. Fabian, I was surprised to learn that there are situations where some at high risk cancer might consider starting medication. Is that the medication you're talking about? How do you determine who that would be right for?
Mainly, we determine that by what your risk level is. For example, if you are at high risk because you've had a prior biopsy showing some precancerous disease, it has words a lot of people may not recognize, like atypical hyperplasia or carcinoma in situ, that is a definite candidate. Oftentimes, unfortunately, these people are in their mid-40s to early 50s. They're going through menopause transition. They already have hot flashes, and they certainly don't want to take medicines that are going to give them more hot flashes. So that was one of the motivating factors for us to develop one of our current main protocols that's looking at giving the combination of a low dose of estrogen plus an anti-estrogen, beta-doxyphene and conjugated estrogen. It's actually commercially available as Duvet. To high-risk women that may not want to, that are eligible for a pharmacologic intervention, that probably don't want to take tamoxifen. So these women are given these drugs immediately or wait 6 months to get them. And we look at different markers in their breast imaging. How does it affect breast density? Or even by fine needle aspiration in their breast tissue. How does this affect breast tissue proliferation, growth, and other things that are known risk biomarkers for breast cancer? So the bottom line is, if you don't want to take full dose tamoxifen, there are other alternatives, whether you're premenopausal or whether you're perimenopausal or whether you're postmenopausal.
You're one of those somewhere in there. So, Mikayla, were you taking any medication?
No.
Nope.
No medications for me.
So we know you have Kansas City ties, but why was it so important for you to schedule your visits coming back here around your appointments at our high-risk clinic?
Yeah, I learned from a dear friend, Megan, who works in your digital communications department, and she had shared with me that KU has a lot to offer, but not just that, that they're an NCI, like what is it, NCI designated comprehensive center, is that right?
You got
Where they're one of the top as far as cancer prevention and treatment. And I've already had positive experiences at KU Med, and so I wanted to go there. And living in Costa Rica, I know Costa Rica has a lot that can provide for our family with healthcare and otherwise. And maybe one day I'll get an exam here or there, but I will be rooted at the KU Cancer Center.
Well, we really like hearing that. Take us through one of your appointments. You fly 3,000 miles. You get here to Kansas City. What are they testing each time you come back? What kinds of tests are they doing?
Yeah, I load up. I load up everything on. I try to keep it into one day, and I load everything up into one day, and I'm just there all day. I take advantage of the cafeteria and facilities and everything there. But I get usually some sort of a scanning, some imaging, and a breast exam, and I speak with the clinician. I also do my my annual there and get as much as I can done. There's usually some blood work involved, and the blood work has a quick turnaround, so it's a nice it's a way that I can get everything done in that short amount of time that I have there.
And because of the history of breast cancer in your family, does this mean that you'll always need preventative care and to be monitored?
Yeah, as far as I know, and honestly, I want to do preventative care in every way of my life that I can to keep myself as healthy as I can. But yeah, that would be something that I think will be forever there with me. Even though I didn't test positive for the BRCA gene, there's enough cancer in my family and in my it's a possibility, and so preventative care is something that I intend on doing forever.
Dr. Fabian, jump in on that.
The reason that Mikayla continues to be at increased risk for breast cancer, despite testing negative for the BRCA2 gene, is because she has extremely dense breast tissue. And individuals that have extremely dense breast tissue are at least at twice that of the average risk person, and 3 to 4 times that of the person that has involutional, or what some of the radiologists term fatty breasts. So Mikayla does need specialized imaging, and I think that's one of the main things that she will continue to need most of the rest of her life.
Hold on one moment, because we're going to show some images that I want you to walk us through just so people understand about dense breasts. But be sure to ask your questions. Use the chat on YouTube or Facebook. You can email the Medical News Network. That information is right there on your screen. So let's talk about this. We have an animation to explain exactly what dense breast tissue is and how it looks or how it doesn't look when you're looking at these images. So take us from the left to the right on what we're seeing.
Okay, so the first image is someone with the so-called fatty breasts that the radiologist may mention on your mammogram report. Basically, this means that the grayness you can see is breast fat, and you see very little white, which are some residual lobular and ductal breast tissue. When we go to the 2 middle images, the scattered density and their heterogeneous density, again, these are generally pretty easy mammograms to interpret, but there is more ductal and lobular tissue. And when we get over to the right-hand side, these women have what we call extremely dense breast, often an area of density of greater than 75%. Because of the increased amount of both ductal and lobular tissue, which you see here is white, of density, number one, it's harder to spot a small cancer, but number two, because of the increased amount of tissue, there's more ways to go wrong, and so the risk of developing breast cancer is higher as well. So it's a double thing. Higher risk, more difficult to spot a small cancer, even with the best of mammograms.
So if you don't have a family history, how are you to know? I mean, it's just through your screening.
You don't until you get that first mammogram.
Well, are you suggesting people do self-exams still in addition to their mammograms?
That's a good question. When they do large epidemiologic studies, there doesn't appear to be a benefit of self-exam. However, I strongly recommend that women be very aware of their breasts, examine themselves at a comfortable place, at least at the same time every month. And if they notice a mass that wasn't there before, that doesn't appear to move around, or feels like there is gravel on top of it, they should definitely contact their provider right away.
But not in lieu of their annual mammogram.
Absolutely.
Do it both. And we say women, but we mean men too, because we've had several men with breast cancer who did catch it in the shower, just showering and rubbing their chest. I want to talk a little bit, because with Mikayla's brother testing positive for BRCA, that mutation, how common is it for men to get it and not a woman, especially when you have a brother and a sister?
Well, they have a 50-50 chance. So if their father or mother has the mutation, they have a 50-50 chance of inheriting it. They do have an increased risk of breast cancer, but their baseline risk for average risk men is so low that still most men with BRCA2 mutation are not going to get breast cancer. There, however, is a substantially increased risk for pancreatic cancer and for prostate cancer. So
again,
people with BRCA2 mutations, we didn't even know this, 10, 20 years ago, but people with BRCA2 mutations are at increased risk for pancreatic cancer. So they need to be, there's a special kind of screening that can be done usually after age 50 for pancreatic cancer in conjunction with high-risk GI clinics. We arrange that here. But they need to be aware of this, keep their weight down, keep their alcohol intake low, avoid getting type 2 diabetes, all the other things that can increase the risk for pancreatic cancer.
We said at the top of the program that knowledge is power, but only if you use it. So what would you say to someone who learns that they might possibly be at a higher risk, but they might hesitate to get that preventative care and come to the high-risk clinic? How do we get people to...
I love the introduction to your segment here, that knowledge is power. Know what your risk is. Know from a high-risk clinic somewhere. You don't necessarily have to, we'd love to see you at KU, but you don't necessarily have to come here. And it doesn't necessarily mean that you have to act on that risk, but know what your risk is and what your options are.
Mikayla, I'm imagining that you get questions from people when they learn about your story or hear about your mother or your brother. What advice would you have to someone who might be hesitant to find out? Not everybody wants to know the news that they may be at high risk of something or feel like a cancer is lurking, but what do you say to them?
Yeah, of course. I mean, first acknowledging that is something that it's honest to be afraid of that and to be hesitant, but to talk about it. That's the part that served me really well, is to just talk about it with people, like just be honest with my experience with my mom, and now I have this new information, and what do I do with it? And I have young children at home, and I'm busy, and how do I? But by doing that is when I was in conversation with Megan, the friend I mentioned earlier, and she was like, actually, I can help you. I can help you get connected with this, and that was the avenue that I was able to get into it. But it just depends. Like if you're talking to a therapist, if you're talking to your family, to your friends, first of all, it minimizes the fear, and when you speak things out, it minimizes how scary they are. And then chances are you're going to run across someone that can just give you that nudge into the right direction.
I want to get to some questions from our viewers this morning. Tiffany wants to know, do soy foods or caffeine have any effect on breast cancer risk?
No. Especially if you're premenopausal, probably soy food may actually help reduce both your cardiovascular risk, and it certainly isn't going to increase your cancer risk. Now, taking high-dose soy supplements, pills, when you've actually had a hormone receptor positive breast cancer, may increase your risk for recurrence. But if you're just at high risk for breast cancer, there's no problem with eating soy-rich foods.
And what about caffeine? Don't take my caffeine from me.
I think you're at higher risk for having dysfunction in your family if you're a high caffeine person. No, I don't think there's any increased risk of
Way
caffeine.
many other issues to deal with when it comes to caffeine or your need for it.
Yeah.
Amy wants to know, do you need a referral to utilize the high-risk breast cancer clinic?
We have actual navigators at KU. You can call the main navigator line if you're interested in a clinical appointment. If you're, and they will get you to the right place.
So that's the number that's on your screen right now.
The number that is on the screen is basically a direct contact to our high-risk breast study coordinators. For example, if you are interested in one of the protocols using low-dose tamoxifen, using the combination of beta-doxyphene and conjugated estrogen because you think you might be at high risk but you're having hot flashes, you can call the high-risk coordinators directly. And if you're not sure why you want to be in the high-risk clinic, you can call them and they'll get you to the right place.
Yeah, they really do. They have the word navigator is key there. They know where to get you. Stu wants to know, besides BRCA, are there other known gene mutations that people at high-risk cancer?
Yes, and they have very strange names. Things like PALB2, P53, but the most common ones are genes that have names like ATM, you know, like your bank, or CHEK2. Those genes are, those last two are what we call moderate penetrance genes. They do increase the risk for breast cancer. They are indications that you should get some supplementary screening with MRI, but they don't increase your risk to 50 to 85% like BRCA1 and BRCA2.
Good to know. All right, Mikayla, thank you so much for sharing your story with us today and joining us from Costa Rica. So lovely there. What do you want people to really take away from your story?
I just a few things. The gratitude that I have for the Cancer Center at KU and for the ability to have access to this, even though I don't have any sort of a diagnosis. The proactive care is immeasurable to me, but also just take advantage of that, be proactive and take whatever small step that you can take to get yourself to better health or to gather that knowledge that you need so you can have the power over your body and your health.
All right. You'll be back in Kansas City, in a few months, I guess, or next year you will. So we'll always glad to have you here. Thanks, Mikayla.
Thank you.
Dr. Fabian, what's the biggest takeaway from today?
I think the biggest takeaway is know what your risk is and understand what your age and risk appropriate screening should be. Most women that consider themselves at increased risk, they probably only need to add the MRI and to do the healthy behaviors that Mikayla is already doing. Mm-hmm. And that is very appropriate for her level of risk. It's really only a minority of women who really, really need to take the drugs. But the important thing is we are developing new ways to help women prevent their breast cancer that do not have the side effects of some of the older treatments.
How exciting is it, though?
I am very excited.
I mean, to live through, like you said, you go back and you say the 90s, but go back to the 80s, and then you go through each decade and just how quickly things are progressing.
It is. It's incredible. It's a very exciting time, I think, for breast cancer prevention.
Always great to have you on our program.
Well, thank you.
Dr. Fabian, thank you so much. Thanks to all of our viewers for being with us today. We'll see you back here tomorrow. Coming up tomorrow on the Morning Medical Update. A cancer diagnosis impacts the whole family. How should parents break the news to their kids? I'm Jessica Lovell on the next Morning Medical Update. From treatment to genetics to end-of-life plans. Hear how one survivor tackled the tough questions. Tuesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.